Starting now. So, okay, this is my first case. I need you guys to take it. So forget the bowel and just tell me what you think about these calcifications up here. You can type in or speak up. Hi, Nelly. I see Nelly's joined.
Hey.
Hey.
There's like lots of, is there free air or is it just a giant cecum?
It was just a giant cecum, so don't worry about the free air and don't worry about the bowel.
So there's these like central, like rim calcified thingies all across the abdomen, like right upper, left upper.
Yeah, it was mostly up,
right
here.
Upper.
Yeah, and then Rubel is saying rim ovoid calcifications. Good. What does that mean to you when they're rim ovoid?
Are they related to the gallbladder?
Yeah, so I was thinking these could be gallstones, but then I was like, they're kind of huge. And then like, is this whole thing the gallbladder? Like that whole shape?
Like a liver lesion with calcifications? Is that weird? Or like
no, that's a good thought. So liver lesions with
like calcs, a hematoma.
Like, yep, could
weirdo.
Be hematoma. Or a liver lesion with calcs could be like a MCN, mucinocystic neoplasm, or I don't know, some old like a echinococal cyst. Any other thoughts? Any other organs?
It's just the right upper, right? Because I see some like stuff in the left upper quadrant too, but maybe I'm just something.
Hey, is it from the right kidney?
Okay, good. So
that's a good one too. Yeah.
Okay, so I think Nelly, you're talking about these guys, and those were just the end of the ribs here.
Oh, okay, gotcha.
Yep. And then another thought, somebody said porcelain gallbladder, so that usually again would be the shape of the gallbladder. And
I like the kidney thing, the atrophic kidney thing that's calcified.
Yeah. Okay, so good.
Like
so
a
kidney. And then another person brought up a calcified adrenal. So that's another great thought, like adrenal cortical carcinoma could have central necrosis and calcs in it. And actually, I think like 30 or 40% have calcifications, whereas pheochromocytomas usually don't have calcs. Okay, so.
This is more time that I've spent on regular radiographs. Shows the CT.
I know. I'm stalling because, well, anyway. I mean, I think it was a good differential. But, okay, so here we are. This patient was 90 years old.
90 years young.
90 years young. And that's their kidney over there. So this was like, very atrophic kidney. And actually these calcifications were vascular calcs in a huge AVF of their kidney. So yeah, so you can see that this is the renal artery feeding this huge AVF. And then this is the draining vein going into the IVC here. And then this is their mega IVC. And actually look at their heart. So we have a theory that that this liver congestion is from this hepatic congestion, but that they're basically in high output cardiac failure due to this renal AVF. So, so this was like the biggest AVF I've ever seen. So just a couple of teaching points about renal AVFs. So these are usually rare in native kidneys. They're more common in renal transplants. So usually you'll see this small little little aliasing flow in a renal transplant, and it's often related to a biopsy. So when I was showing this case to people, everyone was asking like, did the patient have a renal biopsy before? And he actually never had a renal biopsy. 15 years before this, he had presented with hematuria. They found this, they decided not to treat it at the time, and he's actually doing okay for 91 years young. But usually they're like these small little guys. And if you see it here, it usually presents 1 to 2 days after they've had a biopsy. It can cause renal hypertension and hematuria from the renal transplant. And then they might go and embolize it with coils. So you definitely want to get an IR consult. If they're larger like this, or even if you have like an AVF, like from a hemodialysis AVF, it can actually cause this high output cardiac failure. Because it's kind of like shunting everything from the aorta into this sink pool. The treatment would be a coil embolization or a nephrectomy. And then the other thing that I didn't really go into here is that, when we say AVF versus AVM, so AVF is usually these iatrogenic things where it's like a simple connection between an artery and a vein, whereas in AVM, often there's like a tangle of vessels that you might see, and it's usually more likely congenital. I see Yvonne Pedrosa is on. Yvonne, do you have any comments? I was just showing this case of like these mysterious calcifications on this plain film. We were thinking gallstones, liver, eventually got to kidney, and then had this patient with this huge AVF that we thought was causing maybe high output cardiac failure.
No, you did great.
Okay. And do you think, I mean, another thing I read was like when they aren't iatrogenic, like an IVF could be congenital if there was like a large aneurysm and it pulsates and fistulizes with one of the veins. So
yeah, the ones that I've seen, the most common symptom is hematuria, the ones that I've seen. And it seems that that's consistent with what you just showed in your slide.
Yeah. Okay. Any other questions? Okay, this is my next case. Also a plain film mystery. Tell me what's going on in the left lung. I'm sorry, right lung, right lung.
Yeah, I was like,
So I was like, you know,
pneumo.
I was reading.
It's like collapse. There's crappy lungs.
Yeah, sounds like an
What is
abdominal.
that ball of like
lung.
opacity?
Right, but if you think about it, if you look at it, it's like kind of ground glassy and pretty homogeneous here. And then this lung up here looks fine. Rubel says, has there been surgery? Yes, Rubel, there has been surgery. So I want somebody to guess what surgery this patient had. Oh, and yes, she says with packing. Excellent. So yeah, so Patty says a flap. Excellent. So this was the CT. And so the patient had a partial pneumonectomy. So you can see they still have their right lower lung. And then this basically huge open kind of cavity with packing material in it. So that's what we were seeing on the plain film. So this is all gauze in here. And then their chest is basically just like open. So I hadn't seen this before. Rupa's killing it. Oh, Kedar said, yeah, Kedar is. So it is an Eloesser flap, which I had not heard about. But so I'm going to show you guys a couple of points about that. So
how did you come across that case?
A patient in my hospital has this finding, and I was how did I come across it? As I was reading.
You don't have chest, do you?
No. I was reading the the feeding tube, and actually my resident Janet was like, "Cool, look at this," like blah blah blah, and I was like, "What is this?" And then she showed me the chest CT, and I was like, "What is this?" So anyway, this is an Eloesser flap. It was actually developed by Eloesser in 1935, so I'm like 70 years behind the game here. And basically it was more frequently used for TB, but it can also be used for a non-healing empyema where even decortication hasn't worked. And basically they will just kind of, it's like debriding into the chest. So they'll debride they'll remove ribs and the pleura. They keep a skin flap and they'll debride the entire empyema, and then they'll sew the skin flap down. And actually they used to, or I think they still leave a little bit of it open so that it can be like a chronic sinus drainage from there until it kind of seals itself off. Rubel says, I only saw this once on the Thoracic Core series. Well, awesome. Well, you remembered it, so that's great. So yeah, and then there's a reversible form of this that has a different name. I think it starts with a C. But anyway, so this is something you can do to treat a chronic empyema. And I assume that basically, just like they would probably just chronically pack it, and then, it wouldn't be apparent from the outside. Patty says she saw it, probably the same patient. And yes, we have compensatory hyperinflation of the left lung. Okay, my next case is this one. So this is a case that my resident fellow Hernan showed me. So Patty might have seen this one also. I don't know why it's not scrolling. Okay, here. Okay, this patient has had a liver transplant. And they have some unusual connections to their liver transplant. So focus on the portal vein. Hello?
Yeah. So it's
no, take it away.
I'm trying to trace it. It's really hard.
Okay, so I'll go backwards in the portal vein. So left portal vein, right portal
Yeah.
vein, and then it's going into this.
Yeah, it's like an IVC.
Yeah.
It's weird.
Yeah, exactly. So this is an
There's
IVC.
no suprahepatic IVC.
There is here.
Oh,
See,
there it is.
there's
Okay.
hepatic veins, and there's a
There's
suprahepatic
discontinuity.
IVC. There's discontinuity of the IVC, and the
Okay.
portal vein is connected to the IVC. Yeah. So both, exactly. Rubel, Ahmet, everyone's getting it. Exactly. So I hadn't seen this before. I've seen them hooking the portal vein into varices sometimes, into a splenorenal shunt. I've never seen them hook it into the IVC. So I was kind of curious. And if you go down further, you'll see that we don't really see an SVC. So there was, this is the SMA, sorry, this is the SMA, this is SMV, and then it's completely out. And then there's all these collaterals here. Rupa's asking about heterotexy. This was not a patient with heterotexy. So this patient had had a liver failure and then ended up with a liver transplant and another liver transplant. And their portal vein had been thrombosed and their SMV had also been thrombosed. So this is basically what happens when you have complete portal vein and splanchnic thrombosis, which used to be a contraindication for liver transplant. But now they have some creative ways that they can do this. So just going to my slides here. So this is what they call a Cavoportal hemitransposition. And this is basically kind of like a last ditch effort. So normally if you have a portal vein thrombus, it used to be that they couldn't get a liver transplant. Now they can do thrombectomy. Sometimes they can use a portal venous graft, either a synthetic or native graft, like using your IJ, or they can attach the portal vein to like a large varix, such as the coronary vein or a splenorenal shunt. And that will deal with if they only have a portal vein thrombus and they have like a landing zone on the SMV. However, if they have like diffuse thrombus of both the portal vein and the SMV, this is a major problem. Some of the things that they tried was a liver and intestinal transplant. So basically transplanting like the new liver and the entire small bowel with the SMV and SMA. However, this doesn't work very well. I'm not exactly sure why, but maybe it's just too much. Intestinal transplants in general don't work very well. And then they also tried to anastomose the portal vein to the aorta. This is what's called arterialization of the portal venous system or the liver, and that does not do well either. But it does actually fine in the patients who have had this if you connect it to either the IVC or the renal vein. The main problem is that they have portal hypertension. So all the stuff draining from their small bowel is still basically going into this thrombosed SMV. There's still all this portal hypertension. So they still have a lot of ascites and GI bleeding. But actually in the long term, they do okay compared to not getting a transplant at all. So if you've got, what I was thinking was like, this is really weird because like how to, where's the GI tract draining? The GI tract is basically still draining through lots of collaterals. And eventually all of that GI tract stuff will go through the systemic circulation, up the IVC, and then into the portal vein that way. And then also through other branches that will start connecting into the liver. Rupa was saying that it can be confused with heterotexy, yeah. So this is kind of a last ditch effort. If they have both portal vein and SMV thrombosis, you can hook the portal vein into the IVC, and hemodynamically they actually do okay. In the short term, they still have portal hypertension, but in the long term, they actually do okay, and the liver kind of like readjusts to this new input.
So sorry, just to clarify my understanding, if there is a tumor thrombus in the portal vein, they cannot get a transplant, but it's okay to have a bland thrombus.
Yes. So definitely,
and do the transposition thing.
Tumor thrombus is definitely exclusion for liver transplant. But sometimes even a portal vein thrombus, was the difficulty because like they have nothing to sew to, right? So they started sewing them into other places, but even if your SMV is also out, you can't use a graft. So then they start doing these more creative things.
So, hey guys, so
hey.
Our surgeons, sorry I was late. Our surgeons started for patients who have very peripheral tumor thrombi. They actually consider them for transplant, particularly if they're going to downstage the patient, do some sort of embolic therapy, they'll actually still consider them to put, as long as like in the peripheral branches doesn't go into the main portal vein.
Cool.
So
That's
this-
good
Or
to
if it
know.
goes to
I
the main
thought,
portal vein.
Huh?
What
Wait.
about if it goes to the main portal vein, not just the peripheral?
That's some. I think that's a contraindication. I think I've seen them a couple times try to downstage the patient and see if the clot will retract. I don't remember them being successful in that, but for the peripheral one for sure, that they'll still consider it.
yeah, my impression was that main portal vein tumor thrombus is a absolute contraindication. And if it's peripheral, sometimes like, you know, if it's in a very small branch, like they'll, like you were saying, they'll try to downstage it, but it still has a very poor prognosis overall. So it's more like that they know that there's going to be a high rate of recurrence. And so that's why they don't like to do it. I don't know, does anyone else, Yvonne, do you have any thoughts?
No, I agree. We manage it the same way. Even if it's a small branch, if it's unequivocal on imaging, they will treat it as portal vein and not transplant.
Yeah. But Nelly, just, yeah, I don't want to confuse anyone. This case was, there was no tumor thrombus or anything like that. It was just bland thrombus. Okay. And then I have one more case. Okay. Yvonne, actually, this is the one I sent you guys. So this patient had a sleeve gastrectomy and they're now having left upper quadrant pain.
Did they forget to like remove the stomach, or is it just exclude a stomach?
Yeah, so exactly. So for a sleeve gastrectomy, they normally will resect along the greater, sorry, my mouse is having issues, but they normally resect along the greater curvature, and then they'll remove the excluded stomach. So there shouldn't be any excluded stomach here. Whereas in this case, it's scrolling. Okay, as in this case, you can see that this is the suture line along the greater curvature of the remnant stomach. And then this is a tubular structure that also has a suture material along it. It's fluid filled. So that is the excluded stomach that should have been removed. I'll just show you on the coronal as well. So here is the sleeve gastrectomy. And then this is the excluded stomach. So I actually showed a case of this a couple of years ago at SCBT at the Don't Let This Happen to You. But this is something called a retained surgical specimen. So what happens is that during laparoscopic surgery, often they'll kind of remove something. So for example, the gallbladder, the rectum, the excluded stomach, and they'll put it in a bag, or they'll kind of like tuck it away, because they don't want to enlarge their hole and take the specimen out and then lose their insufflation of the abdomen. And then they might do a number of other things. So during a cholecystectomy, they might go do, you know, a intraoperative cholangiogram. During a proctectomy, they might make an anastomosis, etc. And then if they forget to go pick it up and remove it, then that's what's called a retained surgical specimen. So one of the ways, I was talking to one of my surgeons about this has happened, you know, several times. It's a kind of a known complication, especially in this era of laparoscopic surgery. So one of the big things is that you really need to follow your OR checklist, including checking off that the specimen has been sent to pathology. So if you're suspecting this in one of your patients, you could actually go check in the chart and see if there's a pathologic specimen there. And if there's a missing pathologic specimen, then, you know, you kind of have it. But the other clincher kind of is that, you know, no abscess or fluid collection should have a suture kind of line along it. So any questions? Okay, that's it for me. Anyone else have cases?
I have it's not a case, but it's a follow-up of a prior study exam that we did, or
Yeah.
that we talked about. And oh, can you enable sharing?
Yeah.
And I had to look it up because I just didn't have enough information, or I didn't know enough about it. So then I just did a quick
Just one quick follow-up. Yvonne says, partial nephrectomies are at risk for this because of long time between resection and removing the tumor from the body when finishing the nephrectomy. I would say that, yeah, that seems like a big risk factor. So like one of them that I had was like a retained rectum, but it was because they had a couple of hours of like bowel reconnection that they were doing in between, and they forgot about that specimen they had tucked away. Okay, Nelly, take it away.
Okay. So this was, we talked about this before, about sort of liver changes that can happen with patients on chemo. So if I were to tell you this patient is being treated, I don't know, for metastatic colorectal cancer, and patients on chemo, you see this types of distribution of abnormality in the liver, what would you chalk that up to?
I have a couple of theories. Anyone online?
Yeah.
Or so I mean, I guess when I see it, the two main things, with all this hypoattenuation, I'm thinking about fatty deposition,
Okay.
which you can get with chemo, and then the other thing is the SOS. So I'd look to see if they're on like an oxaliplatin, like Folfox, and to see if their bilirubin is rising.
Yeah, exactly. So we mentioned this briefly, so I had to look it up because I didn't really, it's just a knowledge gap that I wanted to close. So this is POHL, post-oxaliplatin heterogeneity of the liver, which happens with patients who are on any kind of like platinum-based, oxaliplatin-based chemotherapy. And there's different distribution. So those are the three sort of, there's a peripheral distribution, a diffuse form of it, and there's multifocal forms of POHL. So you get abnormal transaminitis. So I think you mentioned bilirubin, but so you get AST, ALT abnormalities, and some patients can get low platelets level as well. And it goes away after patient have discontinued treatment, for example. So there are different causes of hepatotoxicities related to chemotherapy agents. The sinusal obstruction is something that's attributed to oxaliplatin and some of these other agents. And then you mentioned steatosis. You get CASH, chemotherapy associated steatohepatitis. That's also attributed to oxaliplatin as well as these other agents. And so just keep that in mind when you see these liver abnormalities with patients who are on chemo, these heterogeneity that we can see.
Nelly, when you said POHL, how does that relate to SOS? Like, is SOS one of the causes of POHL, but then there's other causes of POHL, or are these synonymous?
That's a great question. I think, I need to, I don't want to say the wrong things. So maybe I'll just like copy and paste the radiology paper that looked into this. If anybody has any insights into this, like feel free to chime in, because I don't really know the pathophys of how these.
It's interesting. It says the clinical evidence with clinical evidence of SOS. Yeah. So my experience is that SOS is often a clinical diagnosis. It's often after either oxaliplatin or bone marrow transplants chemotherapy. And with patients undergoing bone marrow transplant, they'll actually weigh them, look for a tender liver. And like if their weight is increasing, their liver is tender, and their LFTs are rising, then they will clinically diagnose them with SOS. And often radiologically, we might not see anything, or we might see this heterogeneous liver.
Yeah. So so I think, based on this like paragraph, it sounds like the heterogeneity is due to SOS. So it contributes to SOS, although SOS can be caused by a lot of different things.
Yeah. Well, the other thing is, in your PowerPoint, you said like it often resolves spontaneously, and I think it does, or it can, but it can also have some implications. Like I've had a couple of cases. This is same thing they call blue liver, SOSs. And so the liver is very, very congested. So if they go to the OR, so for example, if they have colorectal liver mets, and then they give them oxaliplatin, they develop SOS. and they go to the OR and we haven't kind of raised the flag about it, the liver is really congested and it's really hard for them to resect parts of the liver. Like they could lose a lot of blood.
Mm-hmm.
Because it's so congested.
So maybe if we do see it, we should mention it, and then they should wait at least 3 months.
Yeah, I mean, my surgeons, basically, they've called me sometimes and been like, why didn't you tell us there was blue liver? And I was like, I didn't, and so I go back and I'm like, well, there was some mild heterogeneity there, but they said that they should have also suspected it because the patient had been on full phos for like 8 months. So it was like a very sustained also oxaliplatin treatment.
Gotcha. So there's with imaging, there's varying degree of POHL. So like you said, right? Sometimes we can't tell, and sometimes we can. So there's definitely a spectrum of POHL, and I guess we should mention it because then it changes surgical management, or at least helps our surgeons know what to expect when they go in. That's it.
Cool. It can also be caused by Chinese herbs, I found out. If you like Google like images or whatever. Amar says he has a showing tell case. Amar, do you want to go?
Yeah. I'll start. Can you hear me?
Yes. You're a little fuzzy, but we can hear you.
Okay. Can you see the case?
Yes.
So this was a female who presented with the long-standing jaundice. We did a ultrasound and CT before, but it was negative. I'll scroll through the images. It's just a show and tell case. I've never seen a case we see before, so I just thought I'll share it with everyone. I don't know how common or uncommon is it in clinical practice. So the presenting symptom was jaundice. So that's a T2 fat sat image, and this is the MRCP image.
That CBD looked like it was taking a turn and almost had like a little outpouching, like almost like a Santorini seal, or I guess it's like a choledochocele. Oh wait,
yeah, choledochocele, like a
cystic duct channel.
Yes, so that's what we thought. It's a type 3 choledochal cyst or a choledococele. We usually don't see it. Like I try to search the literature as well, but not a lot has been written about it. But they can cause obstruction and jaundice. Here, we didn't find that there is a significant obstruction, but I'm not sure if it can cause functional or some form of dynamic obstruction. In addition, she also had a pancreatic divism. I don't know if they are associated, but again, not much has been written about these cysts. So the pancreatic duct is draining separately from these CBD. So we thought that this was a case of type 3 choledochal cysts. I just wanted to know, have you guys seen, what has your experience been, like, is it that common?
I had one really cool case of a type 3 choledococele, or what we thought was one. It was a huge one, and it was going into the duodenal lumen. And I can show it next time, but it got resected and it came back duodenal duplication cyst. And we even had an EOVIS scan where the EOVIS was excreting through the CBD and into the cyst. And so we said, like, how could it be a duplication cyst if it has, hepatobiliary agent going into it? Turns out a lot of duplication cysts in that area can have communications with the CBD and the pancreatic duct. And the way that the pathologists differentiate between the two is that a duplication cyst will have a muscular layer over it, whereas a choledococele will only have biliary epithelium over it. But anyway, that was my one experience with it. And then in general, people think choledochoceles are associated with abnormal pancreaticobiliary junction, but that would be when there's like longer communication, not like a divisum here.
Well, we did try to think about, once we find this abnormality, I did try to look for the long communication, but in this case, there is a divisum. So some form of congenital anomaly.
Yeah.
Okay. Yeah, that was my case. Thank you.
Yeah, and that divisa might actually be causing something because you've got all those like dilated side branches there too.
Right. Right.
Cool. Okay, Victoria has a case.
Let's see. Share screen. Okay. So, okay, so this is a patient with cirrhosis, and we start out with this 1 centimeter lesion. This is hepatobiliary phase. Can you hear me?
Yes.
Okay, good.
Yep.
So I'm going to show you this is the pre-arterial and portal venous phase. So with this so far we have this pre-arterial and portal venous phase and then hepatobiliary phase. What would you think about in the cirrhotic patient? Or should I just go through Aarti?
I don't have any thoughts on this. You can go.
Apply LIRADS.
Right. So so if I just gave you this and you would apply LIRADS, there would be
Yeah.
LIRADS 3 or 4, right? Because
3, yeah.
it
Or I
has
guess
no-
you can upgrade it, yeah.
Right, so you have no arterial phase hyperenhancement. You
Yeah.
do have washout appearance, probably what looks like washout appearance, right? So that would give you 3. You can kick it up to 4 here.
Yeah.
Right. So let's continue through the case. And this is diffusion and T2. Now you notice that this observation is very dark on T2.
Yeah, like a siderotic nodule or something.
Then we go back into this is out of phase and in phase. So this is the first echo and this is the second, because you can see here that TE is longer on the in phase. And this is the R2 star map. And you can see that the nodule is really, really dark, indicating that there's iron in. And also you can see that the nodule kind of drops signal a little bit on the second echo, again, indicating susceptibility artifact. This is just a kind of a pitfall, right? Because if I just show you these phases, you and I would classify this nodule as what's called, hepatobiliary phase hypointense nodule without arterial phase hypoenhancement. Again, these nodules either get categorized LIRADS 3 or 4. Majority of these nodules end up being either dysplastic nodules or early HCCs. But the pitfall here is that the iron in this in the cirrhotic nodule creates an appearance of hepatobiliary phase hypoenhancement, hypointensity. It's not really that the parenchyma or the cells in this nodule do not concentrate EVIS. It's just the iron completely knocks out signal. Similarly, it's not really washout that we're looking at here, but again, signal loss because of internal iron from this nodule. So this is just a cautionary tale of, and so such nodules should be categorized LIRADS 2, probably benign. These are, there's a separate kind of nomenclature for them. They're called LR2 distinctive nodules. So that's what, and so obviously there's a big difference between LR2 and LR4.
Victoria, I have a question. Why do these nodules develop more iron in them, these siderotic nodules?
Question. There's some, there's, I don't remember the histologic mechanism, but as on the early, on cirrhotic nodules and early high-grade dysplastic, early or low-grade dysplastic nodules, they actually can develop mechanisms where they uptake iron more than the liver. I'll have to look it up and I'll get back to you in exact mechanisms. But the important part to remember is that as the nodules progress through the hepatocarcinogenesis pathway, they actually lose the ability to accumulate iron. So having iron accumulation greater than the background parenchyma actually is a sign of benignity. And it's an ancillary feature of benignity, so you can downgrade the lesion if you notice that.
I'm a little confused by the you said it was an R2 star map?
Oh, T2 star map. I'm sorry. T2 star map.
Oh, okay.
Sorry, misspoke.
I can never figure this out, but can you explain the echo thing again with like the 1.5 versus a 3T?
Right. So if you look at the echoes, right? So when you have dual echo technique, right? One of them, you acquire two images with identical parameters with exception of TE, right? Because you give a pulse and then you acquire one set of images at one time and then the second set of images on the second time, right? So one set of images is always going to have a longer TE. That makes sense, right? But remember that in and out of phase images are not like you can acquire them at multiple points, you know, like at one, this is a 3 Tesla scanner, right? So you will acquire them at 1.1, 2.1, 3.1, 4.1, and so on and so forth. Now you always want to acquire them quickly before the signal loss is gone. So for 1.5 Tesla scanners, the in-phase images are always acquired as a second echo. For 3 Tesla sequences, for 3 Tesla scanners, for older scanners, the gradients used to not be strong enough to acquire out of phase as the first echo. So routinely, they would acquire in phase 2.3 milliseconds and then out of phase at 3.3. And it would become an issue, right? Because iron looms, so there's signal loss on whichever set of images is acquired as a second echo, right? Because TE is prolonged and you have more time to see the T2 star effect take place. The fat always gets dropped on the out of phase images regardless if you acquire it as first echo, second echo. Does that make sense?
Yeah.
Okay. So imagine if you have older 3 Tesla scanner where the out of phase is acquired as a second echo and something loses signal in the liver, either entire liver or just a lesion in the liver, you don't necessarily know if the signal loss is from iron, from fat, or from both. This is not a problem on 1.5 Tesla, right? Because routinely that's not an issue. But for older 3 Tesla scanners, it used to be a problem. With better gradients and newer scanners, it's again not a problem because routinely out of phase can be acquired as a first echo. You have to be aware of this issue because sometimes techs make mistakes. So I don't know how other vendors are, but on Philips, the techs have to select the echo time. So occasionally we do get issues where the out of phase is acquired as a second echo. So you have to make sure you look at the TEs on 3 Teslas.
Victoria, I have a question. If you go back one slide, you know how you were saying like, one more slide to the pre-post. You were saying like sometimes I will call this like pseudo washout because I'll be like, oh, it's like low the whole time, and then everyone told me like pseudo washout is not a term, and so anyway, like I guess you're using the term washout appearance because it's not truly washout, and in this case we know that it's not truly washout. Would you even just say that it's kind of like, why are we even calling it washout appearance if it's kind of like low the whole time?
Right. So fabulous question, and we actually spent an hour and a half. I'm not kidding. That's why I was late to the call. But we had a discussion with LIRADS steering committee of whether this particular thing where you have kind of hypo to more hypo, if this is washout, if it's truly washout. And it was interesting and lively discussion. Technically, as the definition in LIRADS stands right now, this is actually not washout because it goes, as the definition stands right now in version 2018, you have to have iso intensity at least on arterial phase to call something washout. So technically, if you want to be a very, very precise, you would not call it washout appearance based on current definition, but that actually may change. So if the change occur where it goes, where we will accept hypo to more hypo as a definition as washout, this will actually qualify, but this is again a pitfall.
And when you're saying hypo to more hypo, do you use ROIs to kind of like, when you're like, it's not clearly apparent to you? To me, this looks like similarly hypo to me.
Right. So
But I might put ROIs on it. Is that legit?
right. So this was another point of discussion. How do you make sure that something go from hypo to more hypos, particularly in MR, right? Because, you know, on CT at least you can put ROIs, on MR not really. It's up for debate, and you know, right now the assessment of all major features on for LIRADS is based on one qualitative assessment, right? So just visually assess it without using quantitative parameters. We don't have yet established quantitative parameters for any features. We also don't have much data on it. I think there's like one decent paper that looked at quantitative assessment of washout, and it didn't do any better than qualitative assessment. So all these things are up for discussion. But for as of right now, there's no qualitative, there's no parameters for qualitative assessment, like what, you know, 10%, 20%. We don't have the data, and we don't have guidance on that. There's just basically visual assessment. Do you think it definitely became darker than it used to be? Which is my point, is a difficult assessment to make.
Rubel brought up about comparing it to the relative to the liver parenchyma.
Yes.
I guess that would be another, but that seems to me even trickier, because the liver parenchyma is changing so much between the arterial and the delayed.
Right. So that was part of the discussion. You know, if we say something goes from iso to hyper, definitely hypo, there's no, you know, it's clear that there's been de-enhancement. But if you go from hypo to even more hypo, that's more subjective. So it's up and it's all great points, all fabulous points. We're still discussing it. The answer is not yet.
Okay, cool.
Make clear for, if you want to be precise per LIRADS definition, this would not qualify as washout appearance, right? Because it's not ISO. It has to be ISO. It has to have some enhancement on the arterial phase for washout, as the definition stands right now.
And you're thinking about changing the definition because some of these hypo to more hypo actually turn out to be dysplastic nodules.
Well, the definition, the change in definition is driven more partially. I mean, I can bring up the curves and show you, but you know what we're trying to do right here. We're trying to reconstruct the curve, the washout, the enhancement curve, right? And since we don't have the actual, you know, perfusional data, we basically use 2-3 time points with liver as a baseline. So if you imagine, if you have a curve, like, can you see my point?
Yep.
Like, let's say this is the time. If you have a curve like this, right? Like this, it's pretty much washout, right? But if this curve is completely under the liver, right, then it will always be hypo-enhancing. So does that make sense, what I'm saying?
Yes.
So in that respect, you know, in ultimate truth, if you have this curve, it's washout, right? Because the lesion enhanced a little bit and it just kind of lost it, you know, just contrast left. The question is that if all of that curve is below the liver, it's difficult. So this is the conversation. Can we provide guidance for this reconstruction of this curve under the curve of the liver, and still under debate? And the debate started because on CEUS, you can't actually reconstruct this curve even when everything is below the liver, right? Because you're acquiring more data points more continuously. And so in congruence with CUS and quote unquote ultimate truth, can we provide some sort of guidance? And we're still debating that.
Very cool. Thank you for the, I feel like this is like our annual LIRADS, our weekly LIRADS corner. Thank you, Victoria, for educating us. Does anyone else have cases?
I can show a quick one that I saw yesterday.
Yeah.
Let's see, how do I do that?
Just make sure you're not showing any patient info.
Can you see it?
No.
No. Let's see.
Yes, you can see. We can see it now.
Okay. This is a case that I saw yesterday. Pretty quick, but any thoughts? So 34-year-old male.
Seminal
The
vesicles.
SVs are huge. Yeah, it's this layering thingy.
And layering blood, maybe.
Axial at 2 levels, higher and lower. That's the sagittal.
The prostate on the lateral looks very rectangular. It's funny.
And
But I
then
think that's just an artifact.
the high value and diffusion, well, 800 and ADC at this level, and then the same at that level. So yeah, you pointed out the right finding, right? The seminal vesicles are very, very large, and they're like fluid levels inside. The prostate actually was small and normal, and you can see that sagittal view of the seminal vesicle with the fluid level as well, going through that. And it looks a little funny here, but that's actually a normal peripheral zone and normal central zone. It's a small prostate. He's a young guy. This is like the follow-up for seminoma. You can actually see the scar here, and then there's no spermatic cord. But the finding is this very large seminal vessels. What do you think of when you see that?
Yvonne, a couple of people chatted in hematospermia and then also obstruction.
Yeah, obstruction.
Okay. So is a good question. That's in other patients when you have prostate carcinomas that can actually be seen, and cystic dilation of ducts can be seen, particularly in acinar ductal carcinomas, as opposed to the more typical adenocarcinoma of the prostate. But this is again a 34, and that's why I showed the prostate. The prostate looks absolutely normal. There's absolutely nothing other than just enlargement of the seminal vesicles. And it's asymptomatic, no hematospermia. So this is, can be seen.
Retrograde ejaculation. Go ahead.
No, I mean, sometimes you can get seminal vesicle cysts if you have like a Zinner syndrome with like a renal abnormality, but I think it's not usually bilateral.
Very good. So it turns out that this occurs in polycystic kidney disease, and the most common description is cysts of the seminal vesicles. But turns out, and I apologize because I just put this together yesterday just for me, where seminal vesicle cysts occur in 6% of patients with adult polycystic kidney disease, it's much more common to have these megavesicles. 23% of them develop this dilation of the seminal vesicles. So that's, if you see that on a prostate MR or any other exam of the pelvis, just think about imaging the kidneys.
Cool. And so when do you, so like, what's the difference between a cyst and a megavesicle? Like,
so cyst is not communicating, right? You see a typical cystic structure in the seminal vesicles. These were actually clearly, you can follow the seminal vesicles down into the prostate bilaterally. It was just dilation of the vesicles.
Can you go back to the other slide with the content? Yeah. Okay.
okay, Yvonne, we're going to expect you to present more often now that you're a superstar case of the day. And I saw Lakshmi is on too. So Lakshmi, love to have you bring cases. Anyone else have anything? Okay, happy 4th of July, everyone. See you later.
Bye, everyone.
Thank you.